Starting with the next topic, that is intracellular accumulations. Now, while this is a topic which many students tend to pass by thinking it's not very important, let me warn you in the beginning that this is by far one of the most important and the most frequently asked topics. Why so? Because once you read it here, you are going to read a lot of stains, and all those stains are going to help you throughout the systemic pathology part. Having said that, let's begin with intracellular accumulation. What are all the things, be it pigment, lipid, protein, glycogen, calcium, so many things. So without wasting any time, let's start with the first one, and those are the pigments. Obviously, there are going to be some pigments which we ourselves produce in the body, that is the endogenous pigments, and then there are going to be some set of pigments which are coming from outside our body, that is the exogenous pigment. Starting with one such endogenous pigment, and that is the very favorite, the skin color, that is melanin. So when we talk about melanin, please remember, or what you already know, where all is melanin present? It's present in the skin, it's present in the hair, it's present in the eyes. It's a brown black pigment present in all of these places, and of course, no one's going to ask you such a simple question. What will they ask you? Where in the brain is melanin present? Where in the brain is melanin present? And the answer is what you call as locus ceruleus. That's a part substantia nigra. Yes, that is where it's present. So now I want to tell you a clinical correlation to that. So have we all, of course, heard of a disease called Parkinson's disease? If I ask you what is the principle, or if I ask you what is the pathogenesis, what happens in Parkinson's disease? There is a decrease in which neurons? There is a decrease in the dopaminergic neurons, right? The dopaminergic neurons are going to decrease. Now that means there is going to be a decrease in dopa. And is dopa a very important precursor? Is dopa a very important precursor of what? Yes, it's a very important precursor of melanin. That means that if dopa is going down, melanin is going down. So simple, whenever there is a decrease in the dopaminergic neurons and the dopa levels decrease, in the brain the melanin decreases. Now melanin is less, so do you think substantia nigra is going to have the brown-black color? Of course not. That means that because melanin is less, in Parkinson's disease, we have a pale substantia nigra, and that is a question that I will be teaching you when we go all the way up till the CNS chapter. So remember, Parkinson's disease shows you a pale substantia nigra. Okay, all said and done. Now let's begin with what are the special stains for melanin. So the first one that we have is going to be, this is a normal picture. When I say a normal picture in pathology, the pink and blue, I hope you all know the pink and blue is H&E stain. Now when I'm talking about the H&E stain, if we zoom into this has actually been taken from the skin. So what is it about this one that you guys have to know? Please remember, when you're talking about the skin over here, I can see there is a very important brownish pigment that is present along the basal layer. What did I say? It's present along the basal layer. So that means that stratum basal, that is a question in dermatology. Stratum basal is the one that is going to have melanin brown black pigment. And if you want to do the stains for melanin, the first one, why is melanin looking so black over here? Because I have used a stain called Mason-Fontana silver stain. We have used a stain called Mason-Fontana silver stain. And let me tell you one trick for pathology, and I have discussed the same trick for microbiome also. Whenever the word silver comes in any stain, the color that you're always going to get is black. That's a rule that you have for the rest of every lab-based subject. The word silver comes, the color black will be shown. And what is the silver stain here? Remember, M for melanin, M for Mason. But I want to give you a word of caution over here. In pathology, there are lots of Masons. There is a Mason-Fontana in front of you. Gradually in the next chapter, you will have Mason trichrome. So don't get confused in the exam, which M, which Mason. So remember, Mason-Fontana, tanning of the skin, right? So melanin is to do with tanning of the skin. So remember which Mason? Mason-Fontana. Coming to the next one, the next stain that we have, which is getting you a nice bluish greenish color, that is going to be the Schmoll stain. That is the Schmoll stain. How do I learn this? Look at this. Schmoll has the word mole in it. When we say mole, mole is obviously pigmented. It's obviously melanin. So Schmoll stain is the mole stain. Coming to the next one. after this, there are four. So first I've told you Mason-Fontana. Second, I've told you the Schmoll stain. The third is, there are two techniques. If you want to stain it with the help of some enzyme, is there any enzyme histochemical stain that I can use over here? Yes, that very famous stain is dopa oxidase, and most of the question banks that you will see, you will find this question, guys, that which is the best stain that we have for melanin. It's that enzyme, because dopa is what it comes from, right? So that's the best stain, dopa oxidase. The fourth and the last one, there is something called IHC, that is immunohistochemistry. There is something called IHC, immunohistochemistry, and please remember that is what is a very, very important previous year question. HMB 45 and S100. You don't remember S100, I don't blame you, but if you forget HMB 45, it's a blunder. HMB 45 has the word M for melanin. HMB 45 has this word M in it, so M for melanin. So now let's do a recap. I've told you four stains. Quick revision. The first one is M for M, that is Mason. Which one? Tanning, Mason-Fontana. The second one is Schmoll. Schmoll has the word mole in it, so mole is going to actually remind me of melanin. That's how I learn it. Which is the best enzymatic method? The best enzymatic method is the enzyme dopa oxidase. Which is the best immunohistochemistry method? That is HMB 45, also S100. So melanin is done for us. That was a pigment that we are making. Is there any other pigment that we can make? Of course, yes. So the other pigment that we can make is going to be from our blood, and that is hemosiderin. So see, the word only tells us, when I say the word hemo, means I'm going to always have some history of a hemorrhage or a hematoma, something related to bleeding. Maybe it's an accident or a trauma, some blood loss or some bleeding accumulation is going to occur. And if there's blood, there will always be sidro. What is sidro? Sidro is nothing but iron. That is what is siderin. So repeating once again, hemo means blood, sidro means iron. So the pigment that is formed from blood is hemosiderin. How does it look like? Most of the pigments that I'm going to teach you in this section are going to be yellow and brown. So, learning it browns and different shades of brown is not going to help me solve the question. Either I have to look at the clinical aspect, which is hemorrhage, hematoma, or I will have to look out for some buzzwords. And the buzzword that we have over here is refractile. What is refractile? Something shiny. When I can't show you that image because it's a live thing that you see. When you look at it under the microscope, it shines into your eyes as if someone is throwing a flashlight into your eye. So it shines into your eye. So I know the patient has had a bleeding and I'm seeing this shiny thing into my eyes. What is the stain that I'm going to put? Now for iron, we always put the very, very famous Pearl's stain, which is also known as Prussian blue stain. So Pearl's stain or Prussian blue stain is what we have. So remember, now you are seeing that everywhere the iron is looking blue in color. So the name only had it. The name of the stain was Prussian blue. So obviously it's going to give me a blue color. And let me tell you, what form of iron does it stain? It's staining the Fe3+ form of iron. For students who are targeting the INI CET exam, remember there is also something known as the Lilly's method of staining, and that is going to be used for Fe2+. Lilly's for the little valency. Lilly's for the little valency, that is Fe2+. But the main one, the hemosiderin one, that is Fe3+, and that is stained by the Pearls or the Prussian blue. So always remember, there will be a history of a trauma or a hemorrhage or a hematoma, something to do with bleeding that will occur, because of which the patient will have some shiny pigment formed, and you will be told which stain will you use, that is Pearls or Prussian blue. Same way, whenever iron increases, be it a case of hemosiderosis, hemochromatosis, any iron overload situation, the same stain will come up in front of you. The third pigment that we have, again something that all of us only make, is lipofuscin or lipochrome. So what is this lipofuscin or lipochrome? Remember, I call it the old age pigment. It is the old age pigment because you will always see a question as an 8, and I don't know what is their obsession, but they always give you an 83-year-old man. Why is it never changed into 85 or 90 or a 75? I don't know, but their favorite age is 83-year-old man. So this 83-year-old man will be given to you and he will have nothing, no major ailment he will have. But they will say there is a brown color pigment that is seen. So firstly, this is an old age pigment, so I call it senile atrophy. Second, it is a brown color pigment, so I call it brown atrophy. Why is it occurring in old age? Because in old age, we have a lot of free radical injury. What are free radicals? Everywhere around us. All the poisons and chemicals and air pollution and water pollution and every kind of pollution around us. What is it making in our body? It is making free radicals. So imagine if you have a 5-year-old kid and you have an 83-year-old man, who is going to have more free radicals? Obviously, the 83-year-old man is going to have more free radicals. So as the free radical injury will increase, the lipofuscin will also increase. So if I'm seeing lots and lots of lipofuscin, what will you analyze? This means this patient has had lots and lots of free radical injury, because I'll tell you the mechanism now. You know what free radicals do? Free radicals do lipid peroxidation. Free radicals do lipid peroxidation, and that is the reason that lipofuscin is formed. That is how lipofuscin is formed. Okay, so having said that, can I indirectly say that this is telling me a lot of wear and tear? Body is undergoing a lot of wear and tear. That is when it's forming. These are all its names. Lipofuscin, also known as lipochrome, occurs in old age, so senile atrophy. It is brown in color, so brown atrophy. It tells me about the free radical injury. It's a telltale sign, and it tells me about the wear and tear. Now let's look at it under the microscope. So I realize this blue color thing is obviously the nucleus of the cell, and something around the nucleus of the cell that I have is a brown color pigment. But that is exactly what I want to tell you. It's around the nucleus. The problem, or you can say the identifying point, is that this is perinuclear in location. That is how the question comes. You see an 83-year-old or an elderly man with a perinuclear pigment and you don't think of anything other than lipofuscin. The next question that will come is, what are the special stains? So please remember, the special stains are, I'll write them down and then I'll tell you the method of learning them. One is going to be oil red O and the other is going to be Zn stain. I hope everyone knows Zn stain from microbiology. Zn stain is something that is acid fast. So how did I learn it? See, I split the word lipofuscin. Lipo tells me what? It has an element of lipid. If it has an element of lipid, what is the stain for lipid? The stain for lipid is going to be oil red O. Everyone knows. Lipo word, oil red O. That is one part of the mnemonic. The next is F. F for fuscin. F for fuscin, F for fast. That is how we learn it. F for fuscin, F for fast. So what is the acid fast stain that you write? Zn stain. So lipo tells you oil red O, fuscin tells you fast, Zn stain, lipofuscin is done. Moving on to the higher part. Let me show you another picture of how it came in the paper. Will you be able to identify this pigment? How will you identify? Number one, you will spot the nucleus. After looking at the nucleus, you will see there's a brown color pigment that is there, and classically only around the nuclear location. It is perinuclear in location. That is going to be the hint that I will have for lipofuscin. Also, if they give you a black and white picture, if they give you a picture for electron microscopy, again, this is not some rocket science. It's obvious. If this is the nucleus, I am seeing the dark black color things are just around the nucleus. So again, the perinuclear word is actually going to help me solve all the questions. Having done lipofuscin, now we are going to go on to certain pigments which we just need to go through very quickly. So imagine someone is having increase in copper. Can you think of a condition which I'm sure everyone will know, that increase in copper happens in the copper overload, that is Wilson's disease? Okay, Wilson's disease we'll study about when the right time comes in the liver chapter. But when I'm talking about copper, they ask you what are the special stains of copper, and I'm going to remind you of a very famous movie, that is RRR, which of course everyone has seen and there's no doubt about it. So when we say copper, please remember, copper ends with the alphabet R, and the name of the stains are going to begin with the alphabet R. So that is going to be rhodanine and that is going to be rubianic acid. So what are the two stains that you have? Rhodanine and rubianic acid for copper, and the method of learning it is R, and R, the very famous movie. Now, there are two catch points over here, and this is going to actually go with you a very long way. Let me just tell you one thing, and that is, I am talking about rhodanine because gradually you will also study something called rhodamine, and that's the confusion. What did I write for copper? For copper I wrote rhodanine. For rhodamine, remember rhodamine is the stain for Mycobacterium TB. It's a fluorescent stain for Mycobacterium TB. And how will I learn this kind of information? M for M. When I write rhodamine with an M, I am going to think of Mycobacterium TB with an M. Whereas what is for copper? For copper, it's going to be rhodanine. I hope there's no confusion. I'm going to add on to it one more thing, one more box that you guys have to make. I am only talking about copper. I have not spoken about copper associated protein. What is the protein with copper? The protein with copper is ceruloplasmin. The protein with copper is going to be ceruloplasmin. So the stain for ceruloplasmin is the Orcine stain. I will be teaching you much more about the Orcine stain when we come to the liver chapter. But yeah, for the time being, remember, Orcine stain is very, very important. Okay, one more thing. If I can teach you right now, why not? What else does Orcine stain do for us? So remember, I have divided it into OR, means it can stain some organism. CE, because I just told you it can stain ceruloplasmin, and ENE, because it can stain elastin. Let's repeat this. OR, because it can stain an organism. And which organism is it staining? It is a stain for hepatitis B surface antigen. That is why I told you I'll be teaching you once again when we go to liver. Hepatitis B surface antigen is Orcine stain positive. What is CE? CE, I've just now taught you. CE stands for ceruloplasmin. And what is ENE? ENE is going to stand for elastine. So it is also a stain for the elastine fibers, So Orcine stain, some books mention it as Orcine Shikata stain. Remember that, okay? So some really important pearls mentioned out here. Let's do a recap. What are the stains for copper? For copper, we have RRR, that is rhodanine and rubianic acid. But where is rhodamine? Rhodamine is in Mycobacterium TB, fluorescent stain. But this is for copper. What is for ceruloplasmin? The copper protein, that is Orcine, right? Acha, let's finish off the pigments. What pigments am I left with? We have a pigment called hematin. Some books mention hematin as hemazoin also, and I think the infection has already come to your mind. Which infection shows you hemazoin or hematin? That is going to be malaria. Simple. Next, anthracotic pigment. What is anthracotic pigment? It's sounding like a very big fancy name. Anthracotic pigment is what is there in everyone's lungs. That is carbon. So either you're a smoker, that is why you have too much of anthracotic pigment, or you're just living in states like Delhi where the AQI is so bad. So then also you have too much of pollution and carbon into your lungs. That is anthracotic pigment. So basically anthracotic pigment is carbon, either because of pollution or because of smoking. It will be there in everyone's lungs. You see it before every movie where they show you the advertisement of Mukesh, and they also show you an advertisement of black color lungs which they squeeze like coal tar. So next time when you see that advertisement and they squeeze the lungs and coal tar comes out of it, that coal tar is nothing but carbon. That is anthracotic pigment. Lastly, homogentisic acid. Homogentisic acid is also a black color pigment. In which disease does homogentisic acid get deposited? I think everyone knows. Alkaptonuria. Alkaptonuria shows you homogentisic acid, which is a black-brown pigment. Having said that, that marks an end on all the pigments. Of course, the first three, that is melanin, hemosiderin, lipofuscin. That is the most important. Having said that, what other thing can accumulate into the body? And that is lipids. Okay, so first question to you will be whether they say lipid or fat or cholesterol. If they ask you which is the most common organ into which fat is going to go, and I think fatty liver will come to everyone's mind. Of course it will. Fatty liver, but in medical terminology, that is given a little bit of a fancy name, that is steatosis. Fatty liver is known as steatosis. Next question. What if fat goes into the heart? What if fat goes into the heart? So, what is that known as? Let me draw a heart. So, whenever we draw a heart, we like to make the heart very nice and red. So, obviously, most of the heart that I am going to draw is going to be red. But I am saying that now fat is going. If fat is going, this means yellow fat is also going. Is my heart looking red, yellow like a stripe? Is it looking like a tiger? So, we call it the tigered effect or the tabby cat effect? That is again a very important question that we have. So it is known as the tiger effect, like a tiger has stripes or a cat has stripes. So remember, the red portion over here is the normal heart, whereas the yellow portion that we have over here is going to be the fat. So now someone who's preparing for higher exams, let me tell you, where all do you see fat in the heart? So what all conditions? Number one, obviously in case of cell injury, because did I tell you cell injury shows you fatty change? That is why I'm reading it in this chapter. Next, remember there is a cardiomyopathy which you will study all the way when you go to the cardiac chapter. Arrhythmogenic right ventricular cardiomyopathy. Arrhythmogenic right ventricular cardiomyopathy is very famous for showing you fat in the heart. And one infection also can show you, that is diphtherial myocarditis. Diphtherial myocarditis, that also shows you fat in the heart. So remember, especially if you are targeting any central institute kind of an exam, this is very, very important, either as a part of cell injury or a cardiomyopathy or diphtherial myocarditis. Having said that, let me show you some more examples. What if you're dealing with the case of atherosclerosis? If you're dealing with the case of atherosclerosis, this is a picture in the blood vessel that you will definitely find, because atherosclerosis is all about fat and cholesterol. So what are you seeing over here? You'll say these are just empty spaces. Why is fat looking empty? Firstly, I'll tell you, these empty spaces are said to be cholesterol clefts. These empty spaces are said to be cholesterol clefts. So now you'll ask me, where is the fat? Why am I not seeing the fat? Because please remember that in HNE sections, HNE is what? The pink and blue slides. The fat is washed off. The fat is washed off. Why? Why is the fat not staying here? Who made it wash off? Wash off or just flow out? Because when you are putting these stains, you use a lot of chemicals. You use things like alcohol, like xylene. They dissolve the fat. So due to the processing with alcohol, remember, due to the processing with alcohol and other chemicals like xylene, the fat is going to go away. So I only see memories of the fat. I see spaces in which fat, so fat, if I draw yellow color, fat was actually over here. It was sitting over here, but it got washed away. If it got washed away, I'm only seeing the seats, the tables and chairs where it was sitting, but I don't see the fat over there. Okay, let me show you some more examples. One very famous example from surgery. What you see, if I see a green color organ, I know I'm dealing with a gallbladder. And in the gallbladder, can you see too many of those yellow color tiny dots? This is known as cholesterolosis of the gallbladder. Cholesterolosis gallbladder. Cholesterolosis tells me cholesterol deposition, and that is why also called as, because of yellow color spots, it is known as the strawberry gallbladder. Very famous, even viva question in surgery and otherwise also. So remember, cholesterolosis gallbladder is a strawberry gallbladder. And when I look at this under the microscope, what do I see? I will see these cells which are very, very foamy. See, whenever I show you cells, I say cells are always pink in color. Here, there's no pinkish. It's all little looking whitish. Why are these cells looking white? Because these are foamy macrophages. And what do I mean by foamy? So this symbol is for macrophage. Okay, what do I mean by foamy? Foamy means macrophage is hungry, right? Macrophage will always eat up something. So yes, macrophage has eaten up something over here. And having said that, that foaminess is basically, that is, macrophage has engulfed all the cholesterol. It has engulfed all the cholesterol. That is why it's looking so white, because it's full. It's eaten too much of food. It's eaten too much of cholesterol. That is why it's looking all full and foamy, right? That is a classical image of cholesterolosis gallbladder. So many fatty things you have analyzed. Now you must know what are the stains for lipid that we are going to study. So please remember, firstly, lipid or fat, it is very oily. So what is this red color stain that you'll have? Obviously, it is going to be oil, red, O. So no points for guessing that oil, red, O is going to give you a red color. Right? Next one that we have, suddenly the fat is looking black. So we have Sudan black B. Sudan black B. So suddenly it is going to give you a black color. No points for guessing that. The third one is a little tough. Whenever you start seeing an orange color, means you have used something called Sudan 4. Means you have used something called Sudan Sudan 4. So please remember Sudan 4 for orange color. That's a trick over here. Actually, there's one more stain on which you will not get a picture, but you need to know, and that stain is osmium tetraoxide, OSO4, osmium tetraoxide. Okay, so finally, if I have to label it out, first one oil red O, second one Sudan black B, third one another Sudan 4, which is not black, which is orange, and fourth one is osmium tetraoxide. These are all the stains for lipid and everything about lipid. But now one updated question which you have to know. What is this machine? It's a very, very famous machine known as cryostat, and also in simple words known as the frozen section machine. The frozen section machine. So let me tell you guys, let me tell all of you, please remember, whenever I see frozen section is telling me that the temperature inside it is going to be in minus. So yeah, there's something like a minus 20 or a minus 22 degree. That level of temperature is maintained. That is why I'm using the word cryo, because it's minus temperatures. Why am I using the word stat? Because as soon as I will place any tissue inside it, stat, it will freeze. Obviously, it's in minus. The tissue is going to freeze stat immediately. Remember, whenever I want to stain with oil red O, this is the machine that I can use, and this was your JIPMA 2017 question and also once a NEET repeat question. So remember, when do I use a cryostat? When I am wanting to use, I'm not saying oil red O cannot be used on a regular light microscope. It can, but oil red O is very, very commonly used when I'm dealing with this cryostat machine. Having said that, the oil red and all these lipid stories are done. Let's move on to the next, and that is when protein gets accumulated. So I have two situations when protein will get accumulated. Either there is going to be accumulation of too much of protein which is normal. Either there is too much of normal protein, or there is going to be something known as misfolded protein. Misfolded protein. So I'm going to give you examples of both. Let me start with some examples. You'll start understanding a lot of things in a better manner. So first and foremost, please remember the first picture that I have shown you. Right now you might have not studied liver, and I totally understand these are a lot of things from systemic and hemat, but keep going through with the flow. You will understand them eventually when you come to the systemic chapter. So the first protein example that we have is a famous 3 times repeat question, and that is Mallory-Hyaline bodies. That is Mallory-Hyaline bodies. Nowadays, they are also known as the Mallory-Denk bodies, by the way. Okay, so having said that, what are they? Firstly, you will say, where are they seen? They are seen in a lot of situations, but they are most commonly seen in alcoholic liver disease. Let me tell you, I'm not going into the liver chapter. There's a long list of Mallory-Hyaline bodies, most commonly seen in alcoholic liver disease. And the question that is asked is, which protein is it composed of? So remember, it is composed of cytokeratin 8 and 18. It is composed of CK. That is how it is written in the papers. It is composed of CK 8 and 18. CK basically means cytokeratin 8 and 18. It is what is it composed of. Now, having said that, please remember, look at this picture. If you look at this picture and zoom into it, you will realize that yes, I can see that there is a big cell over here. That must be the liver cell, of course. And inside that cell, I can see something more pinkish is there. Same way, let's have a look at another picture. I can see a big cell over here, and inside that I can see something more pinkish that is there. So these are all the Mallory-Hyaline bodies. These are all the Mallory-Hyaline, or you can call them the Mallory-Denk bodies, which are made up of CK8 and 18. They are nothing but proteins, very commonly seen in alcoholic liver disease. What's the second example of proteins that you have? Everyone has heard of a very famous tumor called multiple myeloma. Now let me tell you, multiple myeloma is what? It's a tumor of what? Which cells? It's a tumor of the plasma cells, right? It's a tumor of the plasma cells, and in these plasma cells, what is produced? Lots and lots of antibodies. Plasma cells are famous for producing a lot of antibodies, right? Now, can you see what are antibodies? Antibodies are proteins. That is why I'm reading it over here. Antibodies are nothing but proteins. So now, when I talk about this, I see two pictures. Please remember, this is also a plasma cell. I'm dealing with plasma cell cancer, so obviously I will see plasma cells only. But I see some inclusions. Over here, I see some inclusions in the cytoplasm. These are known as Russell bodies. These are referred to as Russell bodies. So what are Russell bodies? Russell bodies are going to be intracytoplasmic. Russell bodies are intracytoplasmic. Over here, I see another body, but this time it's in the nucleus. So now I'm seeing something called as Dutcher bodies. These are the second one, which are Dutcher bodies. And where are Dutcher bodies? They are going to be within the nucleus. So they are intranuclear. So repeating once again, I have two bodies. The Russell, see, Russell has the SS sound. So where are they present? They are in the cytoplasm. Dutcher are in the nucleus. So there's always a confusion, which is in the cytoplasm, which is in the nucleus. So remember, Russell has the S sound, C sound. So that's in the cytoplasm. Dutcher is in the nucleus. Both of them are made up of what? They are made up of antibodies. Antibodies are proteins. Which, cancer am I talking about? Multiple myeloma. Let's move on to the next one, which is actually something that I'll be teaching you in the endocrine chapter, but the third one is going to be a very famous Crook-Hylene change. Don't worry, you will never ever get to see this picture as a spotter. Don't expect that ever. But you must be knowing what is a Crook-Hylene change? Crook-Hylene change. So firstly, where is the change seen? The change is seen in the pituitary. The change is seen in the pituitary gland. Because of which disease? Because of Cushing's disease. Because of Cushing's disease, we see a change in the pituitary gland, and that is known as Crook-Hylene change. Which protein is it made up of? So remember, Crook-Hylene change, C for C, it is made up of cytokeratin. That is why I'm reading it over here. So if you can see these pinkish color bodies that are coming up, like I said, no one on this planet can identify Crook-Hylene change just by looking at this much of a picture. No, you will always get a history, something to do with Cushing's disease is mentioned, and they will say these are some cells or some change which you're seeing in the pituitary. So that is a Crook-Hylene change that you have. Moving on to the next. Please remember, Robbins has added one table regarding proteins that you have to know. So when they are talking about proteins, they say that either the protein is going to undergo deficiency, that is why the person has a problem, or the protein is going to accumulate and then cause an endoplasmic reticulum stress. So two things, either the protein is not there in the body, that is why the person has a problem, or the protein is there in such a manner that it is creating too much of stress for us. That's a misfolded. Why will it create stress? Because somewhere it is misfolded. Or the situation is both. There's a deficiency also and there's a misfolding also. So let's analyze. So see, these are not something you have to mug up. It will come by common sense. What happens when there is hypercholesterolemia? You must have read in biochemistry, so many cases of hypercholesterolemia happen because of which receptor deficiency? LDL receptor is deficient. That is when the patient is having hypercholesterolemia. So a protein is deficient. That is why there's a disease. Similarly, if there is a mutation in cystic fibrosis receptor, CFTR gene, so that is going to result obviously in cystic fibrosis. If there's a deficiency of a receptor, mutation in a receptor, again a disease will occur. Tay-Sachs disease, I think everyone knows Tay-Sachs disease is hexosaminidase deficiency. Tay-Sachs disease is hexosaminidase deficiency. So again, if there's an enzyme deficiency, Tay-Sachs disease, cystic fibrosis mutation, cystic fibrosis, LDL receptor deficiency, hypercholesterolemia. So one problem is that if the protein is deficient, it is going to result in a disease. The second problem is the protein is misfolded. It's folded in a wrong manner. So for example, prion disease. Which protein is misfolded in prion's disease? The PRP protein. The PRP protein is misfolded. Next, when you're talking about Alzheimer's disease is associated with amyloid, that is A beta. Amyloid is misfolded in Alzheimer's disease. And when you're talking about retinitis pigmentosa, I think everyone knows about rhodopsin from your ophthal studies. That is going to be a problem. So ultimately, as I said, you don't have to go word by word, but since this is a new table added in Robbins, I wanted you to just go through it that protein deficiencies are of two types. Either there's a problem in the, protein is deficient, that is the problem, or there's some kind of abnormal protein present that is creating a lot of stress. Which abnormal protein? Like in Alzheimer's disease, there's amyloid. In prion diseases, there is PRP prion protein. In retinitis pigmentosa, there's a problem in rhodopsin. But where I expect a question is AATD. What is AATD? Alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency. Although we call it antitrypsin deficiency only, I want to tell you, alpha-1 antitrypsin problem affects two organs. One is going to be the lungs and one is going to be the liver. So alpha-1 antitrypsin affects the LNL. So please remember, I think all of you know, in the lungs it causes pan-acinar emphysema. This is from medicine, I'm sure you know, it causes pan-acinar emphysema. In the liver, it causes cirrhosis, particularly in kids. It is actually a cause of neonatal hepatitis and cirrhosis, kids may. So they did a lot of studies and they found out that the lung problem of alpha-1 antitrypsin deficiency was actually because of the deficiency. But the liver problem of alpha-1 antitrypsin was actually the endoplasmic reticulum stress. That was a misfolded protein getting accumulated. So let's do a revision. Alpha, that is where I expect a question. When I'm talking about alpha-1 antitrypsin deficiency, it affects two organs, L and L. In the lungs, it causes emphysema. In the liver, it causes cirrhosis. When I'm talking about the lungs, the problem in the lungs is genuinely because the protein is deficient. The problem in the liver is because there is too much of protein which is all randomly misfolded and sitting over there creating endoplasmic reticulum stress. That is a question that I expect, and that marks the end of the protein accumulation. The three main pictures which I want you to revise. The first one is the Mallory-Hyline or the Denk bodies made up of CK8 and 18 in alcoholic liver disease. The second are the Russell and the Dutcher bodies in multiple myeloma. And the third is going to be a Crook-Hyline change made up of cytokeratin. Finally, coming to what if glycogen is accumulated in the cells? So please remember, glycogen when would be accumulated? When would it be accumulated? Think of some condition which no points for guessing that all of you will write, glycogen storage diseases. So glycogen is going to be accumulated in the glycogen storage diseases. Point number 1. Point number 2, so which is more likely to be asked, in diabetes mellitus, that is in diabetes involving the kidney, diabetic nephropathy, we realize that yes, there is glycogen that goes into the kidney. Which part of kidney, if you can remember from your medicine? Glycogen going into the proximal convoluted tubule, PCT. It's given a very branded name. All of you who are very fond of brands and high-end and very expensive brands, I don't know if you can buy it. If you can, then I'm very jealous. And that is what? Armani-Epstein lesion. Okay, that is Armani-Epstein lesion. So like I said, it's a very branded name. It's a very, very branded name. But what is Armani-Epstein lesion? When glycogen is going and sitting in which part of the kidney? It's going and sitting in the proximal convoluted tubule. You call it Armani-Epstein lesion. So now the next question that will come is, what is the special stain for glycogen? So the special stain for glycogen is said to be PAS. So first and foremost, what is the full form of PAS? PAS is going to be periodic acid Schiff. That is how it's written in the books, and many students call it as periodic. It's not periodic, it's periodic. It contains iodine. It is periodic acid Schiff, and that is the stain which is going to give what color? P for PAS, P for pink. So remember that P for PAS and P for pink is how you're going to learn it. Having said that, guys, there's another thing that all of you have to know, and you must have heard these two terms which I'm going to write over here, which is especially the first one, which is very, very important, and that is they write something is PAS positive. Okay, it will give a pink color, but it is diastase sensitive. It is diastase sensitive. What do I mean by diastase? Diastase is what? The name is only telling you diastase is an enzyme. Sensitive means the enzyme is going to break it. So remember, glycogen is diastase sensitive. If I put diastase, glycogen is going to break away. So first logic, if I put diastase, glycogen breaks. So tell me, if glycogen was giving me a pink color with PAS, right now we told you that glycogen is going to give you a pink color with PAS. But if I add diastase and the glycogen vanishes, if I add diastase and this glycogen goes away, now will you get a pink color with PAS? Now you will not. So can I say it is going to be diastase sensitive? If you add the diastase, glycogen is sensitive, it will vanish away, it will run away. So remember, glycogen is PAS positive, diastase sensitive. So if they give you a question, listen to me, this is not written in any textbooks, it's a matter of understanding. They say, there is a material, you put PAS, it got a pink color. So P for PAS, P for pink. But as soon as you put diastase, the pink color has not come. The pink color has vanished because diastase sensitive. It has broken down. Glycogen is broken down. The pink color has vanished, right? So remember, now a mnemonic. How do we learn glycogen? Glycogen is like girls. Sounds like girls, right? Glycogen sounds like girls, and all of us know that girls love, the favorite most color of girls is going to be pink. That is, PAS is the stain, pink color stain, and girls are usually more sensitive, right? So that is how we learn the story of glycogen. Glycogen is sounding like girls favorite color pink, so the special stain will be a pink PAS, and girls are more sensitive, so glycogen is going to be PAS positive, diastase sensitive. Having said that, the last part of intracellular accumulations that we have is going to be calcification. So we've done pigments, we've done lipid, protein, glycogen. Now we come down to calcification, then we'll make an entire summary table and we'll practice questions. So calcification is a second year pass-fail question which all of you know. You've given your Viva exams or you're going to, and you know this is very important. Calcification means calcium deposition which can occur in two manners: dystrophic, metastatic. What is dystrophic? So I'll give you one, you have to put a blame game. In this calcification, you have to play blame game. Whom should I put the blame on? Should I put the blame on the tissue? So in one of them, I am going to put the blame on the tissue, and in one of them, I am going to put the blame on the blood calcium levels. So that is how I'm going to read both of these. Whom should I put a blame on, the tissue or the blood calcium levels? Okay. So having said that, please know that in D, dystrophic calcification, D, I am going to have a DD, that is a dead and or a degenerating tissue. Either we have a dead tissue or we have a degenerating tissue. So like I said, DDD in dystrophic calcification, either we have a dead tissue or we have a degenerating tissue. This means the problem is in the tissue, which means the blood calcium levels are totally normal. What are the normal blood calcium levels? 9 to 11. So 9 to 11 count is normal of blood calcium. There is no problem in the blood calcium levels. The problem is in tissues. And what problem? DDD. Dystrophic has dead and degenerating tissue, whereas metastatic, the tissue is totally normal. Now over here, the tissues, there is no problem in the lungs, in the stomach, in the intestine, all tissues are normal. The problem is that the blood calcium levels are elevated. So much of calcium is roaming around in the blood. So much of calcium is roaming around in the blood. Where will that calcium go? Where does blood go? Blood goes to all the organs. So even if the organs are innocent, like I told you, even if the organs are innocent, but there is so much of calcium in the blood, that calcium will ultimately end up going to the organs only. The calcium will end up going to the organs. So that means that what is the most common organ affected? And that is the lungs. That is a previous year question that you have. What is the most common organ affected in metastatic calcification? So organs are innocent. Again, organs are totally normal, but there's so much of calcium roaming around in the blood that calcium comes and sits in the organ. So which organ will it come and sit in? And that is going to be the lungs. Okay, having said that, let's take them up separately. So I have understood one thing. In dystrophic calcification, the problem was in the tissue, and in metastatic calcification, the problem is in the blood calcium levels. Let's understand this with the help of examples, and let's do a repeat. So repeating once again, in dystrophic calcification, where is the problem? I am going to talk about either some dead tissue or I'm going to talk about a degenerating tissue, keeping in mind that there is no problem in the blood calcium levels. Now, so let me give you some dead examples. If I say there is a dead parasite in the body, if I say there is a dead parasite, okay, yeah, dead here, so it's going to show me dystrophic calcification. If we see you are dealing with the case of TB also dead bacilli, dead organisms, again, dystrophic calcification. If I talk about atheroma or atherosclerosis, again, atheroma and atherosclerosis has a lot of degenerative processes happening. A lot of cells are dying over there, fat and cholesterol. What is atherosclerosis? It is cholesterol. It is killing a lot of cells. So there also the same process of death and degeneration is happening. Okay. Now I'm going to tell you two very important questions, which are two very important images. The first one is known as Monkeyberg sclerosis. So now this is the toughest to identify because in this word there is no D, there is no dead, there is no degeneration. So let me teach you. What do you understand by, we'll write it again, what do you understand by Monkeyberg Monkey-Berg sclerosis, and the other name for Monkey-Berg sclerosis is CMD. The other name is actually very interesting. You know what do we call it? We call it calcific medial degeneration. We call it calcific medial degeneration, that is CMD. Let's break the word. Question number 1, which kind of calcification are you talking about? Okay, calcific word tells me calcification, but guys, it's a degenerative process. If it's degeneration, which calcification? I will call it as a dystrophic calcification. Okay, where is this calcification occurring, in which part? So question number 2, medial tells me it occurs in the tunica media of a blood vessel. That is the picture in front of you. Look at this. This is a blood vessel with a lumen, and can you see there is a blue color material? In which layer of the blood vessel? This blue color material is in the tunica media. So remember, calcium appears blue in color and is going to occur in which layer? The tunica media. That is why you called it medial. Question number 3, why did it happen? No reason. Degeneration. Degeneration means old age. It is not related to any cancer, any infection, any disease that you are thinking of. No, it is just an old age phenomena. So can I say this is practically not going to have any clinical significance? And that is the question that you got in your previous years again, that what is the etiology that you have for this calcific medial degeneration? We have no etiology. It's just an old age degenerative phenomenon. And because it is degenerative, I will call it which calcification? D for D, dystrophic calcification. This is given a fancy name called Monkey-Berg sclerosis. So that was the next example. And the last example, which will bring a big smile on everyone's face, is Samoma bodies. How can we not discuss these bodies? These are also dystrophic. So let's have an image of this, because I'm sure more than 90% of you already know what are Samoma bodies. These are such a simple and such a well-known thing in medical profession. Okay, so Samoma bodies. First you have to identify. Question number 1, which calcification is it coming under? It's coming under dystrophic calcification. Question number 2, how will I identify? It's going to look round and round and round. Basically, you identify it with the help of concentric lamellations. Concentric lamellations, or if you don't want to learn such a fancy term, look at this, it's going round and round and round, multiple layers. So what is that? That is going to be the onion peel appearance. That is going to be the onion peel appearance. Having said that, where do you see Samoma bodies? That's a famous question, and I'm going to pick up some alphabets. We pick up the P, the S and the M. It is PSM square. PSM square means I'm going to have 2 P's, I'm going to have 2 S's, and I'm going to have 2 M's. That is how Samoma body is going to be identified. PSM square. So P means papillary carcinoma, and let me tell you, most students just end up learning papillary carcinoma thyroid. No guys, papillary carcinoma anywhere in the body. Thyroid, lungs, endometrium, ovary, kidney, intestine, any organ written. Every papillary carcinoma shows you Samoma bodies. Next P, there's a hormonal tumor, prolactinoma. Let's talk about another tumor, somatostatinoma. So prolactinoma and somatostatinoma. Next, in gynae, serous ovarian tumors. Serous ovarian tumors. What is M and M? M is going to be one tumor in the brain, that is meningioma, and one tumor in the lungs, that is mesothelioma. So repeating once again, there is PSM square. So first and foremost, P for papillary carcinomas, P for prolactinomas, S for somatostatinomas, S for gynae tumors, that is serous ovarian tumors, M for meningioma, M for mesothelioma. So one in the brain and one in the lungs. That is all that you have to know about the Samoma bodies, which brings you to the end of the examples for dystrophic calcification. Where was the problem? In dystrophic, the problem was in the tissues, because now I'm going to shift my focus and take you to where the problem was in the blood calcium levels, and that is metastatic calcification. So now all of you are going to understand examples for metastatic calcification, which means everywhere the calcium levels in the blood will be elevated. So let me give you example number 1. If I say hyperparathyroidism, if I say hyperparathyroidism, parathyroidism, all of us know that if parathyroid hormone is more, so for example, name one cause of parathyroidism, hyperparathyroidism, like a parathyroid adenoma or a parathyroid hyperplasia. So basic concept is that if the parathyroid hormone is going to increase, obviously the calcium levels are going to increase. And which calcification will I have then? Metastatic. Let's go by other examples. There are some cancers, some very famous cancers in which calcium levels increase. Two very famous ones are renal cell carcinoma and breast cancer. In renal cell carcinoma and breast cancer, there is also an increase in the calcium levels. Next, imagine someone having vitamin D intoxication. So again, my concept tells me that if there is too much of vitamin D, obviously there will be too much of calcium. So more of vitamin D, more of calcium will get absorbed. Similarly, a syndrome which is not seen too much nowadays, but yeah, was very common once upon a time, again leading to increase in calcium, Milk-Alkali syndrome. Milk-Alkali syndrome also increases the calcium. Next, coming to a tumor, multiple myeloma. Multiple myeloma. Can you wonder why? What was multiple myeloma? Multiple myeloma is tumor of plasma cells. Why is a tumor of plasma cells increasing calcium? Come down to what is the bony problem. What happens in multiple myeloma? We get bony lytic lesions. The bone breaks. There is bony lytic lesions. See, if the bone is breaking, bone has what? Bone has a lot of calcium. If the bone is breaking, where is that calcium going to go? All of that calcium is going to go into the blood. So there's going to be an increase in the calcium levels. Coming on to the last, but saving the best for the last, that is sarcoidosis. In fact, for sarcoidosis, measuring calcium levels is a part of the diagnostic protocol. Why? What is there in sarcoidosis? If you've read the next chapter, that is inflammation, you all know that sarcoidosis shows you a very famous granuloma called a non-caseating granuloma. It shows you a granuloma called non-caseating granuloma. And do you know what this granuloma does? This granuloma makes vitamin D3. It has a production ability. It has a production of vitamin D3. So think logically, if vitamin will increase, if vitamin D will increase, what will happen to the calcium levels? Obviously, the calcium levels will increase, and that is one of the most important points about this table that I want to tell you. That sarcoidosis increases calcium levels. Why does it increase calcium levels? Because it makes vitamin D. Who makes vitamin D? The granuloma makes vitamin D. So these are ultimately, there's no mnemonic needed for it, because if I have this concept in my mind clear that whatever may be the situation, the end result is that the calcium has to increase. So wheresoever the calcium levels will increase, metastatic calcification will occur, and all of that calcium will go and sit in which organ? Going all the way back, all of that calcium is going to go and sit in the lungs. That is what I had taught you. The most common organ affected is the lungs. Having discussed both the types of calcifications, it's time that we come down to the stains for calcium. So first, I'm obviously going to teach you all the mnemonics, and then I'm going to show you the pictures. So what are the stains for calcium that we have? Please remember the way you write calcium. First, please write calcium, and now it has a very K sound to it, calcium, right? So the first stain that we have is a K stain, that is von Cosa. Von Cosa is the first stain. Let me tell you, Cosa is kala. Cosa is kala, so it's going to give us a black color. Cosa is going to give us a black color. So calcium, because it has that K sound, so Cosa. Next, if I look at the full word calcium, it is sounding like calcine. So one very, very famous stain that you have, which I'm going to write as the third one actually, is calcine. You don't have to know pictures and colors of it. You just have to know calcine stain hota hai. Next, if you pick up the next two alphabets, that is AL, and that is going to be alizarin red S. Alizarin red S. So now no points for guessing that what is the color that it's going to give you. It's going to give you the red color, of course, but there's a very famous question for it. So ultimately there are three stains. Can you repeat that for me? Number one, K, Cosa. So calcium is going to be K. So K standing for Cosa. The full calcium that you've written over here is similar to calcine. So that is also one. And the AL that we have is going to be similar to alizarin red S. What are the colors? Cosa gives a kala color, black. Alizarin red S gives a red color. Now, having said that, if we say we have very little amount of calcium in a tissue, what is the stain that you will use for minute quantities of calcium? For minute amount of calcium, which out of these will you prefer? I will prefer alizarin red S. Okay, but how will I learn this? So remember, minute quantity means little bit, zara sa calcium. So what will you use for zara sa calcium? For zara sa calcium, I will use alizarin. So alizarin will tell you zara sa calcium. So whenever you have a little bit of calcium, it is alizarin red S. There's one more very famous stain which is nowadays becoming quite famous, and this is only important if you're targeting the Central Institute exams, or even going forward if you know you want to get extra marks, even if we consider next, and that is going to be the stain known as the Azan stain. So what is Azan stain? It is just a stain that I will be using. It's got many uses, but for calcium, I use it whenever I want to differentiate between mineralized bone, whenever I want to differentiate between mineralized bone and osteoid. So between mineralized bone versus osteoid, and this will help me. This will help me later on because there are some tumors in which osteoid is formed, like osteosarcoma. So whenever I want to differentiate the osteoid beginning wala bone from a proper mineralized bone, that is when I use the Azan stain. Having said that, let me show you some pictures so that you can identify what is this stain for calcium if I tell you. So now from the colors you will pick up. So which is the kala, which is the black one? The black one must be 1 kosa, right? The black one must be 1 kosa. And which is the red one? So the red one must be alizarin red S. And if I want to pick up very minute quantities of calcium, zara sa calcium, what am I going to use? I am going to use alizarin red S. Having said that, that marks almost the end with a few one-liners, and we are done with this topic. The one-liners on calcium that you get. Question number 1. What is the first place of deposition of calcium? What is the first place of deposition of calcium? And that is going to be the very famous organelle of this chapter, that is mitochondria. Right? I told you mitochondria so many places. Where all have I studied? Question 1. What was the first change of cell injury? Mitochondrial dysfunction. Say question number 2. Who played a pivotal role in apoptosis? Mitochondria played a pivotal role. Question 3. Where are amorphous densities formed? The calcium amorphous densities. Which organelle? Mitochondria. Question 4. Who or where is the calcium going to deposit first? Mitochondria. But whenever I talk about a rule, there is always going to be an exception. And that exception is what? Question number 2, that is except the kidneys. In kidneys, calcium doesn't go first in the mitochondria. Calcium goes into the basement membrane. Guys, please remember this. Calcium goes into the basement membrane. So repeat, first place of calcium deposition, it's mitochondria. But when they give you a history of a kidney deposition, then what are you going to mark? You're going to mark the basement membrane. Having said that, we are done with all the accumulation. So it's going to be a very, very rapid review of all of these in one slide so that we know we are on the right track. So let's begin. What are the stains that you remember for melanin? There were 4 stains. Let's do a very quick recap. M for M. So the first one was Mason-Fontana silver stain. Remember M for M, Mason-Fontana. Second one was the Schmoll stain, where mole is the mnemonic that we had learned. Third was an enzyme. The enzyme was dopa oxidase. So that was the enzyme. Fourth one was immunohistochemistry, that is HMB45, which was most important. Coming to the next, lipofuscin. You had to break it into lipo and fuscin. Lipo was reminding you that it is something to do with lipid, that is oil red O. And fuscin was reminding you something to do with fast, so that is Zn stain positive. Hemosidrin. As soon as we say sidro, the word iron comes to our mind. For iron, we have just one stain which is most important, that is pearls or the Prussian blue staining. Coming to the next, what is for copper? Remember the mnemonic RRR? For copper, we had copper ends with an R. So the 2 stains are going to be rhodanine, and the second one is going to be rubianic acid. Rhodanine and rubianic acid. What is for glycogen? I told you glycogen sounds like girls. So with girls, you have a pink color stain, that is PAS positive. And is it diastase sensitive or resistant? Girls are usually sensitive, so it is diastase sensitive. Coming to fat or lipid, again something to do with fat was oil red O. And then there was another black color stain called Sudan black B, right? Although we had other stains called Sudan 4 and osmium tetroxide, but these are the two main ones. Starting with last one, that is calcium. So remember K for calcium, K was for Cosa. So we had the Von Cosa stain. The full calcium should remind me of calcine. So that was one more stain. And for what was for zara sa calcium? Al, that is alizarin red S. So yes, that marks the final summary and your go-to summary whenever you want to revise this chapter. This is something within a minute that you have to go through. These are all the stains that we have. Quickly, let's wrap up this with the discussion of a few questions, and that is the first one that we have in front of us. There's an elderly female who's presented with the outpatient department with the presence of a lump in the right breast measuring 5 by 4 centimeters. At this age of elderly, when they're saying a lump, cancer should be the first thing coming to my mind. And on top of that, they have said the lump is firm to hard. Of course, I'm thinking of breast cancer. Also, they are saying the axillary group of lymph nodes are palpable. Another reason why I think it's cancer. And they have themselves mentioned that there are tumor deposits in the lymph node. There is also, so cancer is certain, tumor is certain. Now let's go to the real story. That is, there is deposition of an amorphous material noted with stains positive for Von Cosa, so this is actually not a cancer story. The twist in the story is that the question has come to us on calcium. Which of the following statements is incorrect? So tell me, grossly, does calcium appear chalky white in color? Of course, this everyone knows. Question option 2, does Von Cosa give a black color to calcium? Yes, Cosa gives a kala color, I know that. Option number 3, the stain for picking up minute quantities of calcium, zara sa calcium, what stain is it? Is it alizarin red S? Again, this is correct. Next, obviously that's the option left, but the first site of deposition of calcium is the endoplasmic reticulum. No, I cannot ditch the hero of the story. The hero of the story is mitochondria. So this is false and this is the answer that we have. Sorted? Let's move on to the next question. Here you have a 54-year-old male patient who's presented with a pigmented lesion measuring 4 by 3 centimeters on the right cheek. So this, my only purpose of making you solve these clinical questions is that no one's going to ask you what is the stain for calcium or one-liner. They link it up with a question from dermat or surgery or medicine and then ultimately come down to general path. So here you have a 54-year-old male who's presented with a pigmented lesion measuring 4 by 3. Biopsy of the lesion has shown presence of atypical cells with prominent nucleoli and mitotic figures. Lots of bad looking cells with mitosis in a pigmented lesion is indicating me towards a cancer, and they have told me that there is a histopathological diagnosis of multiple malignant melanoma that is made. There is a histological diagnosis of malignant melanoma. So that obviously tells me this is a skin cancer. Of course, there's no doubt about it. Which of the following stains cannot be used? That is what you had to read carefully. Cannot be used. So basically, this is a question asking you about melanoma, melanin stain. Is Mason Fontana used? Correct. Small stain, yes. HMB 45, yes. What is not used is Mason trichrome. Remember, I told you just don't learn M for M Mason. Learn which Mason. Mason Fontana, tanning of the skin. So yeah, that will be for melanin. But Mason trichrome is the answer over here. It cannot be used. Why? Because Mason trichrome is a stain used for collagen. For those who've read the inflammation chapter, you've known this. It's for collagen. Coming on to the next question. What is incorrect about the pigment shown? So first identify the pigment. I can see a blue color nucleus, and along with that I can see a pigment around it, which is the perinuclear pigment. This is the perinuclear pigment. As soon as I see a perinuclear pigment, the first thing coming to my mind is lipofuscin. So having said that, what is the first statement? Is it yellow-brown in color? Of course, that is true. Is it because of lipid peroxidation? Yes, I told you that there was free radical injury. Free radical injury was causing lipid peroxidation. Anything to do with lipid is going to be oil red O positive, correct? Is it more commonly seen in infants? Of course not. That is the answer over here. This is an old age pigment. Remember, I kept telling you, you'll get a history of an 83-year-old person. This is an old age pigment. Coming on to one more and the last question that we have for this segment. Which of the following stains is best suited for the diagnosis of glycogen. So if you remember my story of glycogen, girls liking the pink color, you know the answer to this question is pass. So now first and foremost, guys, quickly tell me the others also. Where will you use oil red O? Oil red O will be used for the lipids, fats. Where will you use pearl stain? Pearl stain is used for hemosiderin or iron. Where will we use Congo red? Although we've not studied it right now, but future you will be studying it. It's a stain for amyloid. Very, very important stain for amyloid. But here they asked you for glycogen girls pink, that is pass positive. That wraps up our discussion of the intracellular accumulations and a very important topic that you have in pathology.